right, all right. So today I'm going to, let me go back to my first slide there, jumped ahead a little bit. Hang on here. There we go. So today we are going to talk about the legal implications of perinatal substance use. As you can see from the picture on this slide, we are going to focus on Minnesota, but I know that there are folks here today that aren't necessarily working or living in Minnesota. And so I think this is helpful to just sort of draw attention to what statutes are out there that you might want to be looking into in your own state. And then also we'll talk a little bit about some of the federal laws and how those apply in different areas as well. Both of our Katies will be helping to monitor the chat today. So certainly if you have a question while I'm going through this, feel free to raise your hand, feel free to pop it in the chat. I am hoping that we will have time for the chat today. There is a lot of information on this and I will try to go through it as quickly as possible in the interest of a real comprehensive introduction. But feel free to answer any question or put any questions in and we can go over those at the end of today. So my objectives today are really to go over with all of you some of the current state and federal statutes affecting patients that are affected by perinatal substance use and substance use disorders. This is by no means a comprehensive legal breakdown. I am not an attorney, and so I do have to introduce my limitations as well. I want to talk about the 2021 statute change that affected perinatal substance use reporting here in Minnesota and kind of how we've all applied that. And then I want to talk about best practice for perinatal care here in Minnesota within the context of some of the current state and federal statutes that apply for our patients. I want to thank the Minnesota Medical Association and Hennepin Health for supporting this. This is not only part of our Project ECHO, but also part of their physician forums in emerging topics in healthcare. So thank you for that support. My disclosures, I do currently receive research support from NIH NIDA. I'm on the advisory board of the Safest Choice Learning Collaborative in Massachusetts, which works on education for healthcare providers on fetal alcohol spectrum disorders. And I also personally worked on the 2021 Minnesota statute change that we will review today. So I just want to start by centering us. We all come at this from a different lens and a different life experience. And so I just want to kind of introduce some of the ground floor, if you will, of how we approach some of these discussions. And I first want to talk about person-centered language. So we know that not everybody who gives birth will identify as either a woman or a mother. And so in my work, I really try to utilize the most inclusive and person-centered language that I can, both with pregnancy and also throughout our journey with folks affected by substance use disorders. But I do also have to acknowledge that words like maternal are often used to describe perinatal health events, even in my subspecialty, maternal fetal medicine. And I may be using those when there's no other currently accepted alternative that exists. So I want to start first with a case. And so I'm going to read you a little bit about this case, and I want you to sort of think about this. We're going to talk about it from the perspective that a physician or a midwife or a social worker might experience it. And then we're going to flip it a little bit and talk about how that patient who's coming in for care might see it. So this is 28-year-old patient who's coming in to initiate pregnancy care. During the routine substance use screening that was done in that clinic, she identifies that she used opioids daily, mostly fentanyl. The healthcare provider discusses the risks of use and you talk about the dangers for long-term health and offer a referral for substance use treatment. The patient opts not to initiate treatment at that time. And this is imagining you're in 2021 prior to the statute change. I inform her, you know, Minnesota statute mandates that if you identify that you are currently using controlled substances and they are not prescribed to you, that I do have to make a report to your county of residence. The patient becomes very angry and leaves without scheduling another appointment. So certainly for any of you who have experienced care prior to mid-2021 here in Minnesota, this is unfortunately a familiar scenario. But let's think about this from the perspective of the person who's coming in. So this is a 29-year-old mom to a 6-year-old daughter working full-time, hasn't really been feeling well for a few weeks. And so you take a pregnancy test, it's positive. Okay, you take your lunch break, you spend 20 minutes on hold trying to get through central scheduling. You finally get a first pregnancy visit that's scheduled, but you can't get in for 6 weeks. You've been using fentanyl and needing to use daily just because if you don't, you start to feel really sick. And that's a scary and awful place to be. And it's becoming more and more expensive. You're using more and more just to kind of feel normal. And you know you need to get in for treatment, but you just don't know even like where do you do that? You know, you don't even know if your insurance covers it. You didn't have insurance for a long time, and you're really worried about calling your employer to see if they even have addiction coverage. Is that going to get back to your boss? Are you going to lose your job? What's going to happen from this? You know you're a good parent, and you know that your daughter is supported, healthy, and safe. You do everything you can to provide for her. But you just need a little more time to kind of get things arranged, figure out what you have off for time, figure out where you can get in, and you know that you're probably going to have to go to another clinic, and that's going to take more time off of work. So you come into your first provider and you tell her, you know what, I'm using fentanyl daily. I think I'm going to need some help. I'm just not there yet. I got to get some stuff together. And the healthcare provider tells you, you know, she's going to contact Hennepin County because that's where you live. It's one of the large counties here in Minnesota. And if you don't get into treatment, she might actually have to put you on a hold. If you're not agreeing to do what she wants and what you need to do to keep that baby safe, she's going to have to put you on a hold and force you into treatment. And you're so frustrated at yourself. You know, you thought, well, I met this person. They seemed really understanding. I thought they were going to help me, and they definitely don't understand what's going on. And you leave without scheduling another visit. And so I think that's really interesting when you hear someone's story when they're coming into your clinic or you're getting them ready, that this is a real person with a real life and the same sorts of difficulties in scheduling healthcare and taking time away from family and job to get the help that they need. And so on that same sort of journey, I want to talk about some of the misconceptions and some of the shared perspectives that we should all start to consider and incorporate. And I think it's really important when you're talking about pregnant people or parenting people with substance use or substance use disorders that continued drug use cannot be assumed to reflect a lack of desire to quit using drugs. There's limited insurance coverage that exists for substance use treatment, and treatment can often be very expensive if you don't have insurance coverage. Very limited space is often available. And one of the problems I see most importantly for my patients is that treatment often doesn't accommodate childcare, family, or work responsibilities. I think about when patients come in to see me. It's from 8 a.m. to 4:30 p.m. So if you've got a full-time job, it's hard to take off. I don't have the ability to accommodate children. And I don't necessarily have the ability to allow them to bring their entire family, especially in the pandemic. I want to move on to that to a really important recent publication by the Office of the National Drug Control Policy, or ONDCP, which established on this same vein 5 key values that we need to consider when we're talking about pregnant and postpartum people who are affected by substance use disorder. And I think these are really important values for all of us to incorporate. So having substance use disorder in pregnancy, simply having this medical condition, is not by itself child abuse and neglect. And I think that is the most important of these values as we look at the laws that we have in our state, the laws that we have in our country, and the narrative that we see around pregnant and postpartum people. That we know that criminalizing substance use disorder in pregnancy is ineffective and harmful. We know that everyone has a right to access effective treatment, and that pregnant people using substances should be encouraged to access support and not turned away, and should be encouraged to access care systems without fear of criminal retribution or losing their children. And really what we need to do as all of us look at improving this is that we know that improving how we coordinate with our public health folks, the criminal legal system, treatment, early childhood systems, all of these working together are going to optimize outcomes and reduce inequities for both the birthing people and for their families. So let's talk a little bit about the data. Before we look at the laws, I think we need to know, and we must stop to acknowledge what is going on in this country right now. And as we look at how things have changed in the pandemic, our situation has become more critical and more dire to start addressing these in a dynamic fashion. So this is looking at the overdose deaths, and this is not just for pregnant and parenting people, but in the United States, going from 1999 until the 12 months ending in April 2021. So really looking at how this was affected in the pandemic. And as you look at the numbers of that red line and the deaths per year, I want to highlight the fact that when the war on drugs was declared by President Nixon, when it was identified that we had a crisis in this country, there were just under 7,000 people per year dying of drug overdose. Entering into this last year, we had over 100,000 people in the United States that died of drug overdose. And you can see on here that this is primarily driven by opioids, which is the light blue line, and most dramatically in the last several years by synthetic opioids, which is primarily fentanyl. When we focus on Minnesota, we see that we've not been spared from this. So in Minnesota, we look at where our predicted cases is. Now, these data lag a little bit just because we have to look at death certificates and confirm things. But we anticipate that in 2020, where we had predicted, it was about 858 deaths. And in April of 2021, we had about predicted that we've come out with 1,188 deaths related to drug overdose. This is a 38.5% increase in drug overdoses in our state. There's a great research letter that was just published in JAMA, and this allows us to really focus more on pregnancy and both pregnant and postpartum persons. What I want you to focus on here is the drug overdose mortality rate per 100,000. This left square is looking at the change, really examining what has happened in the pandemic. From 2017, in pregnant or postpartum people, it was 6.56 per 100,000, and it increased to 11.85. When we look at the numbers for all reproductive age people who identify as women, which is the right side, age 15 to 44, we see a similar increase where we had pretty stable numbers, 14 point something for 2017, 18, 19. It jumped up to 19.76 per 100,000. And when we look at the absolute relative change, what is most concerning for the work that I do is when we look at the relative change for pregnant or postpartum people, we see an 80% increase in drug overdose mortality rates. And you contrast that with all reproductive age people who identify as women, and you see a 37%. 37% in and of itself is a scary percent increase, but really we have a critical issue that needs to be addressed in our birthing population. This is looking again at that same pregnant and parenting over time, kind of breaking it down by what substances we worry about. And you can really see on the left side, when we look at the drug types involved, that this is primarily being driven by fentanyl, which is in orange, and other synthetic opioid analogs. And something that I think needs to be getting more attention, which is the light gray, which is psychostimulants. And this is primarily driven by methamphetamine and cocaine. When we look at the timing on the right side, so where are these folks dying from substance use and from drug overdose? Early postpartum, which is that first 42 days where most people in most states still have insurance coverage, has stayed relatively stable. That's the orange line. But where we've seen that jump is in pregnancy, often in people who are not able to access care for a variety of barriers, and especially in our late postpartum period. That's 42 days to 365 days after delivery, where many people in states lose their insurance coverage. We are very lucky that we've had expanded postpartum insurance coverage here in Minnesota. We do not have individual data for this from our state right now. So what does this really mean? It means that overdose has drastically risen surrounding pregnancy. We need to stop and address this. And it really is a unique time because most people who are pregnant are inevitably going to have some sort of health system interaction during the childbirth or the miscarriage or the termination process. And so we know that we've got to focus on during and after pregnancy and look at ways that we can engage people in care for those outcomes. So let's talk about the statutes, because that's really why all of you came here today. And so what I want to first do is talk about the change that I think a lot of people are hoping to get some information and guidance on today, and that's on Minnesota perinatal substance use reporting. For context, we'll talk a little bit. It's always important to know the history. Before July of 2021, perinatal substance use reporting was mandated, except for alcohol and cannabis. This was identified as from many providers and from some data in the state as a barrier to universal substance use screening. Why? Because what people were seeing who were in the clinical venue is if I screen a patient and that patient discloses to me substance use, I am required to report them to their county of residence at that time immediately. And many of us who are working in this field were losing patients. We were telling them that we were required to report them and they were disappearing from care, or we weren't telling them. And then they were all of a sudden having someone show up at their door and then they didn't come back. And so this was really seen as a barrier to universally screening people, which we know is recommended by most of our national OB/GYN pediatric midwifery groups. Mandatory reporting has been shown in the data as a factor in decreased perinatal care access. And in fact, we saw in this state during the period of mandatory reporting that a large number of our folks whose babies went on to have withdrawal from opioids, what's called neonatal opioid withdrawal syndrome, were patients that had limited or minimal prenatal care. And so we do know that decreased prenatal care has been associated with an increase in adverse pregnancy outcomes. And we'll talk a little bit about the study that really drove our push to change reporting in the state. So this is just looking, it's always nice to have these available. This is previously what we called mandatory reporting entailed. So a person mandated to report, and we can kind of go over the list of who that is. So there's mandatory reporting for a variety of really child endangerment and neglect. And this includes healthcare providers. It includes, anyone who's interacting with someone within the healthcare system, people that work in our criminal legal system, people that work in child welfare, people who work in the clergy. There's a large list within the statute, but essentially you were to immediately report to the local welfare agency, that was by county, if you know or if you have reason to believe that a person was pregnant and had used a controlled substance for a non-medical purpose during the pregnancy. And there was a carve out that you did not need to report THC or cannabis and alcohol. And this is just the context as of 2021. It's always nice to look at what are the other states doing. And so this is showing in red all of the states in which, as of 2021, healthcare workers were required to report drug abuse or substance use during pregnancy. And at that time, there were 15 states that required this, and we were one of them. So mandatory substance use reporting, what have we seen in states that have this? We know, and we see this, those of us who work in clinical settings, that many patients leave care after initial reports. They're scared to engage in initial care because they're fearful of what's going to happen next. They're afraid to be honest and transparent and partner with their healthcare providers. And providers are fearful to screen patients because they know once they screen, they are required to report. And what do we use to really push our legislators and our support teams here in the state to understand why this was so harmful is this article. And this is a wonderful article that was done by El Mohandes in 2003, looking at 4 large hospital systems in the DC area and really looking at a cohort of patients who got prenatal care. And really looking at when you have infants with prenatal substance use exposure, how does that change their pregnancy outcomes? And what they found is that prenatal care reduced preterm birth rates, even with ongoing substance use. So even if the patients had no access to substance use treatment or declined substance use treatment, if they came to regular prenatal care, which was defined as 80% of the visits that we would be expected, their babies were more likely to be born full term. In addition, their babies were more likely to be normal weight. And so you have something which simply by nature of getting patients to be less scared and more trusting, that if we don't report patients and then they disappear because they don't feel like they have that relationship, we can actually improve things for the babies. So through this and through a 3-year process, and I really want to thank the tireless efforts of all of the advocates through so many organizations and disciplines that helped us advocate through tireless hours to change mandatory reporting. And this is what has changed as of summer of 2021, July of 2021, that we now say that a healthcare professional or a social service professional who is mandated to report is exempt from reporting if the professional is providing or collaborating with other professionals to provide the woman with prenatal care, postpartum care, or healthcare services, including care of the woman's infant. If the woman does not continue to receive regular prenatal or postpartum care after the healthcare professional has made attempts to contact the woman, then the professional is required to report. Now, I think we always have to understand that when laws are written, they are not as specific as those of us in healthcare would like, but that's because there's just a lot of different circumstances and nuances that need to be worked out. And often some of the people that are working on these laws may not have as much detail or lived experience in caring for folks that the rest of us might. So what did this change? So this changed that if you are a provider, you are not required to report pregnant patients when they first identify substance use. How does this help? It allows time to develop a therapeutic relationship. It allows the patient to get ready for treatment if and when they're ready. And it also allows them to continue to come for care even if they aren't ready for substance use treatment. And you as providers know that they are going to have pregnancy outcomes. Now, I think it's important to say that it doesn't tell you you can't report. And so anyone always has an option to report anyone that they have a concern about. But I think for those of us who really had concerns about building a trusting relationship with patients, this gives us the option to do that. So what changed? I think the conditional requirement to report. So what I tell patients is, I ask them, are you familiar with kind of reporting laws in pregnancy? Thank you for sharing with me. And you need to understand that even if I'm not reporting you right now, if I can't find you, if I don't know you're okay, I do have to file a report with the county of your last residence because I don't know that you're okay and I need to know that you're okay. The questions that come up, and we don't know yet, we're all still sort of trying to figure out how this ends up being defined. Does care in the ER count? So if the patient isn't coming to me, but I see she's coming in, every month to check in on the baby in the emergency room, if she's going to her WIC appointments, if she's going to her perinatal psychiatrist, does that count? What does continued and what does regular care mean? And I think that part is a lot more nuanced perspective, and it takes a lot of interpretation, which may be at a health system level and maybe at an individual provider level. So who does this apply to? So this is the list of everyone who is a mandated reporter that this would apply to. There's been some concern that this is only for doctors or only for midwives, and it doesn't involve social services or psychiatry or childcare. But this is the list from the statute of who mandatory reporting applies to. So what are some of the implications? And I will tell you that I have seen a lot of benefits firsthand. I have so many more patients who are engaged in ongoing prenatal care. I have patients who are engaged in care who relapse and are willing to come back to me to seek help again, even with ongoing substance use. So I have definitely seen an improvement in patients' willingness to trust the system. But I also acknowledge that less patients are accessing the resources that are linked to mandatory reporting in counties with supportive programming. So counties such as Hennepin and Ramsey, and I'm sure many other counties across the state have some real robust services that help our patients. And if they're not being reported, it may be more difficult for those patients to connect with those systems because the programming just doesn't know they're out there. And so I do think that this does bring up an opportunity for us to really address programming revisions. How do we expand service access? How do we get people to know that there are services there and to trust those services without constantly living in fear that getting the help that they need to support them through WIC, through so many other things, is not going to result in them losing their child. So I want to kind of move on and identify that prenatal reporting, the mandatory reporting change was simply for prenatal reporting, but there is a lot more nuance that goes into this with our pregnant people. And this legislation change only addresses mandatory reporting of substance use in pregnancy. It doesn't address any of the other legislation related to toxicology testing in pregnancy or testing of infants surrounding birth, or reporting of infants with prenatal substance use exposure. So there's a lot of work left to do, and there's a lot of education on what changes in the practice that we have. So let's talk a little bit about toxicology testing, because I think this is one where we've had a lot of confusion after the law change. So there is a separate statute in Minnesota that says that a physician shall, not may or must, or not may, but shall administer a toxicology test to a pregnant woman under the physician's care or to a woman who is under the physician's care within 8 hours after delivery to determine whether there's evidence that she has ingested a controlled substance if the woman has obstetrical complications that are a medical indication of possible use of a controlled substance for a non-medical purpose. So two things I think that are important to call out in this. It doesn't say a physician shall with the patient's permission. And here we have a conflict between patient autonomy and assault and what our law is telling us to do. And I think it's also important to call out that really that physician is only required to do this if there are obstetrical complications that you can look at and say that might be related to prenatal substance exposure. Not because a patient's been in a methadone program before, not because the patient told you she used cannabis when she was 16 weeks of pregnancy, but that she comes in or they come in and have an obstetrical complication where you say this is related to substance use. And I think this clarity is really important as our systems start to look at how to change our testing. So I think it's also important to call out that urine toxicology is a horrible way to find out if someone has a substance use disorder. There's a very short detection window. It does not test for alcohol or tobacco. There are some alcohol metabolites you can test for, but not with our standard urine drug screen. And importantly, in many of our systems, we don't even test for fentanyl. It's a special call out or special order. And with the ubiquitousness of fentanyl, and that's what's killing our patients and affecting them with opioid use disorder, this is a problem. It doesn't capture binge or intermittent use. So somebody might use, 4 or 5 days a week, but they might not have used when that test was there. It's not a trust building method to open discussion. You come into the patient like, oh, I did this urine on you and you didn't tell me you were using, and now I found this. It's not linked to intervention and referral to treatment for substance use disorders. False negatives and false positives are a real concern. There are a lot of things that cross-react. I'll give an example. Labetalol is a medication we use as one of the standard treatments of high blood pressure, and it can cross-react with methamphetamine. So you've tested a patient who comes in with one of the criteria for delivery or for obstetric complication that might be associated to substance use. It comes back as positive, and you're in this very uncomfortable situation where they didn't know you were doing the test, and now they are telling you that they didn't use this substance, and they really might not have. And I think the biggest concern is that with this biologic testing, we know that there's been criminalization of the use of toxicology during pregnancy to penalize our pregnant and recently pregnant folks. So this is just looking at the amount of states in which testing is required if drug use during pregnancy is suspected. There are 4, and we are one of them. And it begs to question, if the overwhelming majority of this country does not have this testing, should we be examining whether we should be changing this policy in our state? So what does this mean? We talked about obstetrical complications. Well, I just want to give an example of historically what the criteria have been in a lot of the large health systems here in Minnesota. Now, I will acknowledge that a lot of us are doing work to change these, but this is an example of things that are not necessarily meeting the law, the letter of the law. So physical signs of drug use, such as visible tooth decay. Is that an obstetric complication? Or is that a sign of poverty because you don't have access to dental care? Sores on the face and arms, limited prenatal care because you couldn't figure out how to navigate accessing insurance. And so I just draw this for all of you to go back and look at the criteria that you're using to meet this statute within your institution and really think about, are the criteria you're using truly helping your patients? And if not, are they meeting the statute as currently aware? These are the criteria that my system has currently developed. Now, I will say that as you are changing your criteria, it's really important to look at them and identify, are they discriminatory based on a patient's socioeconomic status? Are they discriminatory based on structural racism within your hospital system? And are they really things you need to be testing for that are benefiting your patients? And we'll talk a little bit about the data we know on this. There is a lot of compromise that needs to happen. If you decide not to test folks who identify that they have used substances during pregnancy or are identified as being in a treatment program, there may be other people or collaborators in your system who aren't yet at a point where they feel comfortable using a verbal or written screening tool and really want to keep these criteria. And so this is sort of where we've landed. The ones on the left are the ones that our system and our pediatricians, family medicine, addiction medicine, maternal fetal medicine, OB, all reviewed this together and decided, yep, these are obstetric complications that I know are associated with substance use. Somebody comes in with altered mental status. Somebody comes in respiratory arrest in the field. A seizure that's not related to a seizure disorder, preeclampsia, a stroke, a heart attack, or cardiac arrest. All of those can be linked to potential substance use in pregnancy. We also decided to keep the ones on the right, and this is primarily because if we knew patients had disclosed substance use in pregnancy, we really just wanted to get that information, especially with our pediatric collaborators, to be able to identify those babies and watch them appropriately and kind of talk to the parents ahead of time about what that would mean. So those aren't necessarily meeting the statute as it's written, but it's something that our system felt strongly about preserving in our screening criteria. I will say that some systems, and this will depend on legal and risk management, may have very strong opinions on whether you can do this without a patient's consent. There are very clear case law where physicians, midwives, other healthcare professionals have been charged with assault for performing procedures on patients, especially in pregnancy. C-section is a great example where patients did not consent. And so I always want you to think about that and have that conversation with your legal team as well. So these are our newborn screening criteria. Those first criteria are the ones for which we screen a pregnant person when they come into our labor unit. For our newborn screening, we screen any patients who met criteria for screening, and also the newborns of patients who decline screening for themselves when indicated. So we do allow patients to decline urine toxicology screening when they present at our institution. Any clinical signs in a newborn that would be consistent or concerning for withdrawal from in utero substance exposure. And then we also recommend screening any abandoned infants that fall within the safe harbor exception. Excuse me. So I want to talk a little bit about the data that should make us sort of think about, is urine toxicology and the statute as it currently stands, excuse me, the right thing to do for our patients? And what is the goal of this toxicology testing? Is it to identify pregnant people for treatment? Is it to identify babies who might benefit from more intensive care after delivery? This is an older study, but this is a study which looked at prospective screening of all new OB care patients. So patients came in and anonymously identified if they had used substances in their pregnancy, and then anonymously provided a urine drug screen. And the interesting thing about this urine toxicology, which really wasn't much different than what we're using today, was only 50% of people who said, I have used substances in pregnancy, had a urine toxicology that was positive for any substance. So clearly this was not picking up the majority of our patients who might benefit from some sort of additional help. I think more importantly than that is some of these conditional screenings that we've used have a significant potential to be applied in inequitable fashions. And in fact, good research out of Northwestern in the last couple of years really identifies that this is the case. So they looked at their system and looked at urine drug toxicology and looked at the reasons it was done and how it was applied. And the only testing indication that was actually associated with a positive test was that when patients reported current or prior substance use. A lot of the pregnancy complications that we've historically used, abruption, hypertension, preterm labor, really didn't pan out as being significantly, that if you screened for these indications, there was a high likelihood that your patient would have a positive toxicology test. And I think more important to me when we are using this as screening is that Black birthing people were 4 to 5 times more likely to be tested for indications that were not associated with illicit drug use. There were urine toxicology in which no indication was documented for 9% of white birthing people and 20% of Black birthing people. Now, I think for context, it is important to establish that when you look at all racial and ethnic groups in the United States, prenatal substance use and just substance use in general, the percentages are very similar across all of those groups. So we shouldn't see this. And this really raises the question of structural racism in the way that we address toxicology and substance use. And in fact, the odds of toxicology testing for indications other than someone telling you they have had an issue with substance use disorder in the past or currently, you were over 3 times more likely to be tested if you were a Black birthing person. So urine toxicology is not an appropriate way to screen for substance use, and without guidance, it certainly can be used in ways that reinforce bias and structural racism, but it's the law to use this testing in Minnesota. So I want you all to think about what is the best thing to do for our patients within the structure of this current legislation, and the logical next step, which is, should we be looking at changing this law to more equitably support our birthing population? So I want to talk real quick about a couple of other things. One that comes up a lot in my institution, and I think across the state, is declining substance use treatment in pregnancy. So we let people decline C-sections. We let people decline antibiotics in labor. We do not often let people decline substance use treatment in pregnancy. And so I want to talk about two partnering statutes that address that. What's called emergency admission, or a 72-hour hold. You may just hear it being called placing a hold, and then civil commitment. And so this is the placing a hold or emergency admission is essentially that if there's a peace officer or health officer, so peace officer, some of our criminal, legal, and police type folks, if they or someone working in a health officer or healthcare role have reason to believe through direct observation or reliable information of a person's behavior that you are worried that they are in danger of harming themselves or others, that they can be detained to be placed into treatment. And that's the part where we primarily see this in pregnancy, but also in pregnancy with mental health treatment. So the one that we see the biggest is this part: if they're chemically dependent and in danger of harming self or others, if they're not immediately detained, that a patient may be taken into custody and held for up to 72 hours, excluding weekends and holidays. They need to have an evaluation by a healthcare provider within 48 hours in a court hearing as soon as possible to talk about the possibility of commitment. So this is a 72-hour hold. What we will often see happen, and we'll often get calls, is this patient is pregnant, they're declining to go into treatment, or they were in treatment and they absconded or left against medical advice. They need to be placed on a hold. What I have also seen is a patient who chooses a termination of pregnancy or miscarries, and then the folks who've asked me to place them on a hold no longer place them on a hold, because in fact, it wasn't that they were a danger for themselves, but there was this belief that they were a danger to an unborn pregnancy and that you were protecting this unborn pregnancy from the patient, despite the patient not wanting to go into treatment at the time. The next step after a hold or a 72-hour emergency admission is a pre-petition screening to place that patient on a civil commitment. This is a petition that goes through the court, requires a written statement by a health examiner, and then that court hearing needs to be done within 14 days. But as that's happening, a patient can remain in involuntary treatment. These are the states in which substance abuse during pregnancy is grounds for civil commitment. Again, looking at the entire country and raising the question, why are there only 3 states in the upper Midwest that have this? And what do the data tell us? Because you think, okay, if I can get this person into treatment, they will change their mind on what is right for them. And what we know from some really well done recent studies is that individuals who are subject to involuntary treatment are 2.2 times more likely to die from overdose compared to those who enter treatment voluntarily. That 34% of patients surveyed who had been civilly committed reported relapsing to drug use the day they were released. Less than 20% of patients who were in civil commitment for opioid use disorder received the standard of care, which is medication treatment with buprenorphine, Suboxone, Subutex, methadone. And that only 7% of those who were released from civil commitment followed up with addiction treatment after release. So it really doesn't seem like this is getting our folks to where we believe it should be. And I think this is in contrast with a recent survey of addiction medicine physicians in which 60% of them favored the use of civil commitment. So it seems like it makes sense from our training, but the data are telling us it is not working. And so I want to just talk about kind of one practice perspective, and you should all sort of think through what your policies are related to holds. The practice in which I currently work has made a practice-wide decision some years ago not to place a hold on a patient simply for their being not ready to enter substance use treatment at the type of care. This supports ongoing collaboration. We make sure they have our phone numbers. We make sure they have Narcan if they have an opioid use disorder or ongoing opioid use. We make sure that they know we are ready for them to change their minds, and it's not going to be an I told you so, but it really allows us to develop trust with patients. We have no data that we have found that involuntary treatment is helpful, and it actually may be harmful, but we do place holds if a patient is a danger to the self or others. For example, I had a patient who came in who was in the middle of an overdose. When we were able to revive her and I was able to have a communication, I said, I almost saw you die. I believe you are a danger to yourself. I cannot let you leave until I know you are okay. And that patient wanted to leave immediately. And I placed her on a hold until I knew she was better and she could breathe safely and I could contract with her to come back if she needed to. Not until she complied with every aspect of the treatment that I thought she needed, but because I felt that she was at risk of dying if she left. Likewise, if someone is telling me they are suicidal or telling me they are homicidal, we in my practice do not support homicidal being ongoing substance use in pregnancy as that person being a threat to their pregnancy. I want to talk a little bit about something that really creates a lot of confusion in our state, and that is CAPTA. And I think those of us who work in the OB world may not be familiar, as all of our folks who work at WIC and Child Protective Services and social work and pediatrics. And CAPTA is a law that's been around for some time, but has had some modifications in 2010 and 2016, specifically to address the concerns of infant well-being for prenatal substance exposure. So this is CAPTA, stands for the Child Abuse Prevention and Treatment Act. This involves federal funding of states and tribal organizations, and again was modified as we address the ongoing and worsening opioid epidemic and the increased rate of neonatal withdrawal. And really what it was trying to do is ensure the safety and well-being of infants following discharge, to make sure that those folks experiencing substance use disorder have the resources to keep themselves and their infants safe after delivery. And the requirement at a federal level is that we are required to notify CPS of the occurrence of a child's birth when that child has had prenatal substance exposure, and to have a plan of safe care. This specifies at a federal level that this notification does not constitute a federal definition of child abuse. So the federal law is saying just because someone has substance use disorder does not mean they were abusing their child prenatally. However, half of the states in the United States currently consider substance use in pregnancy as either prenatal child abuse and/or prenatal child neglect. So Minnesota, here in our state, substance use prenatally is viewed as child abuse or neglect. And here are the states in which substance use currently during pregnancy is considered child abuse. Now, we have to acknowledge that when a lot of these laws were passed, we had a very little understanding of what substance use disorder is. It's now very clearly established in the data that substance use disorder is a medical condition. We do not consider someone who doesn't treat their diabetes as prenatal child abuse, although we know untreated diabetes is clearly associated with an increased risk of stillbirth and neonatal complications. We don't consider uncontrolled blood pressure prenatal child abuse and neglect. Why is this medical condition treated differently? And a lot of it has to do with so much of the legislation and the conversation that happened starting in the 70s and even predating that in this country. But I do think it's time to revisit that as a conversation. So I want to talk a little bit about what they've done in CAPTA with CAPTA in Connecticut, because I think it's a nice idea of how we might be able to pivot with some things here in this state and in other states that may have the same issues that we do. So Connecticut has used a novel pathway in which a substance exposed infant is evaluated after birth and kind of dropped into these different sort of buckets, if you will. So there are infants who had prenatal exposure, but they talk to the birthing patient, they talk to her family, her support. And the team that evaluates her, the social worker, says, I really don't have any concern for abuse or neglect. Yes, this patient has substance use. She's getting to where she needs to go. She has a plan, but her using substances or the family, there's no concern. And so they submit a de-identified CAPTA notification where they notify the CAPTA system, the federal system. I have a patient who had prenatal cannabis exposure, but I don't have any concerns for abuse or neglect. If there is a concern for abuse or neglect, those folks either have a plan of safe care and are referred for state maltreatment reports. So they're really worried, this patient is struggling and I have concerns for abuse or neglect. And those will be separated into two groups, ones that have a plan of safe care and ones that do not. Now, I will acknowledge that in Connecticut, prenatal substance abuse is not categorized as child abuse or neglect. So they are able to sort of tease these things out in a more detailed way than we might be able to right now. So what did they find in the first 2 years that they changed their reporting? Interestingly, 8% of total Connecticut births were identified as having prenatal substance exposure and needed to notify CAPTA. 3/4 of these notifications involved cannabis, and just over half of them involved only cannabis. And so the overwhelming majority of these were folks that had some exposure, but they were identified as not being associated with abuse and neglect. 21% of the notifications involved opioid exposure. Not surprisingly, looking at the same sort of things we saw applied with that urine screening, Black birthing people were disproportionately overrepresented in notifications. They were, when you look at these and look for actual evidence of abuse and neglect, you don't see that there's a higher level in Black birthing people. You just see that they are disproportionately represented in notifications, despite the fact, again, that substance use is pretty equivalent across groups. And interestingly, over half of the identified substance exposure cases, all of whom would have been reported for potential prenatal abuse or neglect in Minnesota, were diverted from CPS reporting. In their state, they really differentiate between a report and a notification. So the report is, I think that this baby is at risk of neglect or abuse. I need to have those support systems, or that child may not be able to leave the hospital with the parents. A CAPTA notification is, hey, I had a newborn who had prenatal exposure to cannabis. We have a plan of safe care. We're done. And so I think this is a really novel way to address how we are evaluating our patients and their families. So to summarize today, we have statutes in the state that guide care with perinatal substance use. And it's really important, whether you're working in Minnesota or you're working in other states, to take the time to look at the statutes that apply to perinatal substance use, speak with your risk management about them if needed, but really understand when and how those are applied, and look at the language of those statutes. There are a lot of unintended consequences of our current statutes at both a state and federal level, both the recent reporting that we changed and some of the ongoing statutes that I do feel may cause unnecessary harm to our patients and families. And I want to have this be a call to all of you, both here in Minnesota and beyond, that we need to advocate for examining our statutes, looking for revisions and modifications, especially in older statutes where just so much has changed. Just look at our toxicology one. It says a physician must administer. It doesn't even acknowledge the fact that we have a large percentage of births in this state that are attended by midwives and might not even have any physician input. So let's start to update these, not only for who's caring for the births, but what we know about substance use in pregnancy, what we know about structural racism in a lot of our systems in this country, and what we know about substance use and substance use disorders. And so I really want us to work both as providers and administrators within the system to reduce maternal and newborn adverse outcomes by making it easier for patients to disclose substance use and then to give them those wraparound services that they need afterwards. So I have all of my references here, and I want to stop at this time for questions from any of you in the audience.
I have a question.
Yep, go ahead.
What, in your opinion, would wraparound care look like? What would it consist of? And what at this time, who is ready to be doing that?
I think we have a lot of great folks out there that we need to coordinate to say, what do we have in the state? What do we have for peer recovery for both patients that choose to be in recovery and patients who aren't there? So what sort of peers do we have to support patients? What sort of, doulas with trauma-informed care and substance use lived experience, working in treatment programs? What do we have for that? What do we have in WIC? What do we have for parenting support classes? And what do we have for people who are ready to go into treatment? Do we have supportive housing? Do we have family programs that we know can work for our folks? So I think we've got a lot of great stuff out there. How do we coordinate it? And how do we do it in a way that people can find out about services without having to have a mandatory report? And how do we get them to know as providers, hey, I really think you should go to talk with somebody from Project Child, because I think they actually have a lot of great tools that can help you, without it being, hey, I reported you because I don't think you can safely do this on your own, and I need to have something forced on you. The services are great. It's just, how do we get them connected without it being a fear-based referral?
Sounds like we need a clearinghouse of resources.
It sounds like we need a state, something at the state level that allows us all to sort of get together and make those sort of recommendations, whether it's a clearinghouse or even just a group saying, we know these things are there. How can we use these more effectively?
Yes. Thank you.
All right, I'll take the last question because I think there's a fair amount in the chat, and then if Katie sees anything after that, but there is a question in the chat saying, do you know if there are any automatic mandatory statute change based on the Office of National Drug Control Policy recommendations, specifically the substance use in pregnancy being neglect by definition? This is a great question, and I was so delighted to see this report from the White House and the ONDCP, and I would encourage you all to look at it. The link is in my references, because I really love this sort of key tenets of how we should approach prenatal substance use. I think that this is very much still in its infancy, and there's a lot of conflict today between what we want at a federal level and what individual states are doing. We see that a lot after the Dobbs decision, and so although the federal team has identified that this should not be considered prenatal child abuse and neglect, how we convey that down to the national level is yet to be seen. But I definitely would like to see something in which this is removed from the criteria for prenatal abuse and neglect. Next question is, what has the general response been from pediatricians or other child healthcare providers in response to these statute changes? I will say that I had a lot of positive experience with our pediatric providers once we started collaborating, because I think as a prenatal provider, you see it as, the pediatricians are trying to keep the baby safe and making sure that they do everything to identify withdrawal, but aren't necessarily doing what's going to keep the patient engaged in care. And then the pediatricians see it as, I am potentially creating an environment in which folks are missed, which is not what we are intending to do. And I will say that when we have sat down and talked about it and looked at the data, we both want the same thing. We want a healthy pregnant person, a healthy parenting person, and a healthy newborn. And there's so much data now that out-of-home placements are so harmful for the parents and for that baby. And so how can we keep in-home placements, but bring in those support services as well? And if the patients aren't ready for those services, how can we make sure that they're able to parent in a safe environment? And so I would say when we actually communicate and don't sit in our separate silos, sort of pointing fingers, we've really found that we all want the same thing. And it's really easy to make decisions once we do that.
Cresta, I was wondering on this note, as kind of a call to action, I feel myself wanting to help advocate for some of these potential changes you had suggested. And I also find it hard to know where to start. I'm curious if people want to get involved or make change, your recommendations of kind of where to start.
Yeah, I mean, I will say first, I'm always happy to take if, my email's on the slides, if you're like, hey, I work for, this doula program and we really feel strongly about this and we want to advocate. I do work with Minnesota ACOG. We do a lot of work in this realm, and we partner with ACNM and, Minnesota Society of Addiction Medicine. We are looking for more folks to kind of get on that team with us. That's how we got the mandatory reporting passed. I would also say a simple thing to do, which is kind of how I started a lot of this, is you can email your elected officials at any time. You don't have to sit down and write a letter and take it to the mailbox. You can come up with sort of a template letter and send it to your elected officials. And that's what I've been doing as things change and there are healthcare concerns, is reaching out to my state rep and my state senator, reaching out to the attorney general and just saying, hey, here's what I do for a living and here's how I see this. And I would love for you to reach out to me with any questions you have. I'd love to serve as a resource. And I also, hey, did you know that this law is disproportionately affecting folks that we need to advocate for? I think that that's a really good way to start. I've also had meetings with my representatives, and we have an OBGYN who is in the state legislature right now, and she's been very open and a huge advocate for getting this legislation passed. We now have 3 physicians that are in our state house and just in the state legislature who can be really great at spearheading this. I will say the thing that you have to be willing to do is to testify. And that's super scary. But they need folks like us who have stories. And it doesn't have to be, I am a maternal fetal medicine, addiction medicine expert who knows all the academic stuff. It's, hey, I work for WIC and I have seen this happen. And here's an easy way we can change to gain our patients' trust. So your voices are so important. And we're all so busy and so burned out, quite honestly, after the pandemic, that we're not aware of the power of our own voices. So emailing me, reaching out to your elected officials, emailing an elected official and asking to have a Zoom with them. There's so many powerful ways that you can do this. Or going to your hospital administration and saying, we ought to think about what our criteria are for urine toxicology, or we might want to think about running it past risk management if we should really be doing these urine drug screens without patients' permission. Anyone else?
Just quick, I heard at one point that Project Child was going to be kind of expanding where it doesn't end with childbirth, but they help after that as well. Do you know anything about that?
I don't know anything about that, but I would certainly say that sounds like a fantastic idea, because not only at the national level, but when you look at our data on the Minnesota Mortality Review, we have a lot of patients who are dying past that 42 days postpartum. So, really looking at that entire year afterwards, if we would have more ways to identify patients who are struggling with substance use, to identify patients that are struggling with depression, anxiety, suicidality, and so many other things we know can adversely affect them. I would love that. I would love for there to be more time and more connections with those patients. So I think I would love to see that at the county level and really even as a state priority. All right. Well, I want to thank so much all of you. Let me just make sure there are no additional questions here. We've got a lot of great links. I would have you take a couple of minutes to look at the chat. We have the Physicians Day at the Capitol. I know that ACOG and Minnesota Medical Association are active with that. So many others. There's some links to, a TED Talk kind of talking about this, and other folks who are doing work in this space. Reach out to us, Katie, or me, if you have any additional questions or other ideas for how to work on this. And thank you for all of you for showing up. This just, obviously shows that there's a lot of people that care about this, and that's only going to help our patients. So thanks again.
Thank you, everybody, for being here. And thanks, Cresta.